So we put forward our proposal for Keystones of Health, Bridges to Success, Keystones of Health for Pennsylvania, back in early January 2024. And that began a process where we do through negotiations with the Center for Medicare and Medicaid Services, otherwise known as CMS, to do implementation planning, to get approval for standard terms and conditions. And we are very glad to share with you, for anyone who may not have heard already, that we did receive full CMS approvals for the 4 components in November and December of 2024. As we look forward, we are going to be looking at a phased and stepwise implementation of the plan. We want to start with our proposed budget investments for state fiscal year 25-26. That would put approximately $4.8 million into the reentry supports program in order to leverage additional federal resources to begin the work of planning for the reentry initiative in partnership with our state correctional institutions. We do note here that all future implementation is contingent upon budget appropriations from the General Assembly. While this particular portion of housing is not in the governor's proposed state fiscal year budget, it's really important that this Looking Ahead series works together collaboratively to help us determine what would be necessary for implementation. Once we receive that approval in December 2024, it starts the clock on some required deliverables. So over the next few months and over into this fall, we have required deliverables due regardless of the year we implement. So it's a great time for us to be connecting and come together on planning for success. And we can move to the next slide, please. And in this, we wanted to spend a bit of time for folks. We know that some people are very familiar with our 1115 waiver. We really appreciate the interest and engagement along the way. And others may be coming to this conversation new or returning it for the first time in a while. So an 1115 demonstration waiver, this basically allows states to waive certain rules that govern Medicaid programs. CMS allows these to be major innovation pilot projects that meet the general goals of Medicaid to help people live healthier lives. Approved 1115 waivers operate as 5-year pilots, and there are requirements for independent evaluations to measure effectiveness. So great new tools, federal authorities. It's important to note that these are not obligations or entitlements. We are able to really target these interventions. And these waivers, we've seen them approved in other states. They address health-related social needs and reentry programs already existing, but add new tools and capacity to get interventions to scale. We'll move to the next slide. Thanks. So we wanted to talk a little bit about what are health-related social needs. So it's a new set of programs. It would address what we've often been calling social determinants or social drivers of health. Many of us are far more familiar with that term, and it's going to be where you have a social determinant of health and the intersection with a critical life transition for a particular individual. So where social determinants of health is often at that larger macro level, the health-related social needs framework is really looking at that intersection where you have an individual during a critical life transition with an or undermet social need, and determining that that's an appropriate place to intervene to ensure access to care and improve health outcomes for that individual. So in this, it's really going to be emphasizing that this is time limited, but setting up for success in new ways that we have not had these tools before. And we can transition to the next slide. So in this work, we did want to talk a little bit about the larger proposal again for catching folks up who may not be familiar or haven't heard it in some time. So with this, it allows us to look at engagement to build on national research, local pilots and programs. As we began this process, we engaged with different stakeholders and communities around the Commonwealth and learned about what folks are doing, what is working, where they have gaps, where there are needs and opportunities, and how we might scale some programs for success down the road. And we are able to really look at these to look at addressing reentry supports, the housing supports, which we'll spend the majority of time on today, food as medicine, as well as some targeted continuous eligibility policies. And we can transition to the next slide. So the first, I wanted to spend a little bit of time talking about the reentry opportunity and why we're starting here in that stepwise implementation plan. So this opportunity actually came about during the Support Act, which was a bipartisan act of Congress in 2018 during President Trump's first term. And this was a directive to CMS from Congress to develop a specific waiver opportunity to improve reentry and improve transitions back to the community for folks who are at risk. So this is something that is a little more prescriptive. It came out with the state Medicaid director letter that really said these are the specific interventions and service we want to see in order to support folks. And in that, we want to see the reduction of overdoses, help people with avoidable hospital use, and this would allow us to improve public safety. We know that recidivism costs the Commonwealth approximately $3 billion per year. So we really want to set people up so that they're not having that revolving door back into these systems. And we can hit the arrow to add the new tools. The big things here is that this would provide intensive case management as well as targeted substance use disorder care to folks up to 90 days prior to release and facilitate warm transitions back into the community through ensuring continuity of care, as well as to be able to reduce risks. The hope here is that we'll be able to develop stronger connections between inside the walls and outside the walls. And there are many great folks doing this work already, but they haven't necessarily had tools and resources at the scale that they would hope for. And it'll give us some new capacity to be able to deliver and build for this group of folks and improve for the future. And we'll move to the next slide. So in housing, we know that there is a clear and established evidence base that is growing with regards to the connections of housing and health. We know that homelessness and poor health outcomes are linked. When folks are in poor health, we have high utilization that could be preventable or avoided. We want to look at developing housing supports focus on the highest risk populations. So we've seen some other states put forward these proposals. Sometimes they do say we will support any Medicaid beneficiary who is experiencing homelessness. We are really looking at some targeted populations that are smaller, where we believe that we can truly achieve and show and demonstrate those outcomes based upon the risk factors and improving that continuity of care and experience. So I love seeing the hearts in the chat. Thank you. I'm glad that you're as excited as we are about that, and we can put to the new tools. So an important context here within Medicaid is we are not trying to take over or change existing systems. We want to connect to existing housing supports and services and build bridges between them. So there are folks out there, continuums of care, as well as community-based organizations, homeless service providers, public housing agencies. Many caring community partners are doing the work to try to connect people experiencing homelessness to housing and the supportive services that they need. We've often heard that they have not had the resources they need at scale, and a lot of that is often driven by a shortage of access to housing across our communities. So this aims to develop some new partnerships between folks who maybe haven't worked together as directly in the past. We are very cognizant of the fact that many of the individuals and case managers and providers delivering these services currently, you have likely not been billing Medicaid to deliver these services. So it is a really transformational change that we want to work with all parties to set up for success down the road and make it easy to participate in these activities to improve access. The ability to go into the interventions we'll talk through a little bit further, but I'll talk through some of the game changers that have been made available through these new approvals. And we will talk about the national priorities on the next slide. So I wanted to pull out a couple of things that I think are really pertinent here. As I mentioned, unfortunately, we have seen that the growth in homelessness is often driven by a lack of housing. There was a report from Harvard that demonstrated for the first time over 50% of American renters are cost burden, meaning they're paying more than 30% of their income towards rent. We see the National Alliance to End Homelessness note that they're helping more people sleep inside, get access to emergency shelters, but many systems and communities are not able to keep up with the increasing demand for their resources and exit folks from these systems. We saw that in order this, we need to scale up rental assistance and supportive services. The latest point in time count, which is an annual count required by the US Department of Housing and Urban Development as well as Congress, showed that there was a fairly significant increase in homelessness in Pennsylvania just over the past year, a 12% increase to over 14,000 Pennsylvanians experiencing homelessness on a given night in January 2024. So the time is urgent, the need is urgent across the nation, and Pennsylvania, this is a priority for us as well. And we can move to the next slide. So wanted to note a few of the things that the Shapiro administration has been doing in this space. We were really excited that in 2023, we changed our Medicaid program to allow certain Medicaid enrolled providers to bill for services rendered outside of a traditional brick and mortar clinical setting. So we basically, for this, it's often called street medicine. And this is something that has been in existence, sometimes partnerships with universities, with community-based providers, with hospitals. And historically, it's been something that's been delivered, but not able to be reimbursed by Medicaid. So we're really glad that we were one of the first states to advance this. And then later in October 2023, CMS made it nationwide, and the Commonwealth has taken steps to add new eligible provider types. And it's been really fantastic to see and get to know some of the growing programs and new programs starting up in the Commonwealth, sometimes at teaching hospitals. So that's been fantastic to see that can help folks to build that access to care, build a trusting relationship, and then ideally attach folks and refer folks to some of our more standard clinical systems, or develop the relationship that makes someone say, yes, I'm willing to enter into housing, or I'm willing to talk to coordinated entry to be assessed for eligibility for other programs and services. The other thing we wanted to note is that Governor Shapiro in last September, he signed an executive order, and this directed the Department of Human Services to work alongside our sister agency, the Department of Community and Economic Development, as well as Pennsylvania Housing Finance Agency, the governor's office, sister agencies, and folks all across the Commonwealth to develop and deliver Pennsylvania's first statewide housing action plan. And there was a specific note directing us to address work to improve coordination of resources and supports to the unhoused and to address homelessness. So we are hard at work planning for an interagency council on homelessness, and the 1115 waiver will be an important part of potentially delivering these innovations and bringing together partners together in really meaningful ways to improve our coordination and reduce homelessness across the Commonwealth. And we can move to the next slide. So, as we noted earlier, we firmly believe and know that homelessness and high-risk health conditions, it is a recipe for, unfortunately, poor outcomes and high costs. We see folks who are entering into emergency rooms, who may be interacting with our first responders in ways that are unavoidable, or cycling in and out of correctional institutions. We want to ensure that we have these new tools to improve access to care and to increase our housing stability over time. And we'll move to the next one. Thank you. So going back to where we've been and where we're going, we had the opportunity, and we're so grateful to talk with a lot of folks who are doing this work around the Commonwealth. We heard about different partners who are addressing supportive housing. We heard about folks who are using Medicaid community-based care management to do some mediation and eviction prevention in our communities. And we heard again and again that while there are individual efforts happening, that folks often get stymied and that they need more support and resources to be able to partner meaningfully and to bring housing and health entities together. Many of us are fond of our acronyms. We speak different languages. So this is an opportunity for all of us to come together to learn and partner in new ways and change how we deliver services. We did public sessions, public comment. We had that approval, review, and negotiation period. I will note here that the approval process does include some terms of budget neutrality, and that we see that some states do have capped expenditures across some of these services. Part of that process is approving specific populations that can be served and approving housing support services definitions. And we can go to the next one. Thank you. So for the approved populations, as I noted, we are looking at a targeted set of populations with folks who have those high-risk conditions. So we are proposing to support individuals experiencing homelessness who have a diagnosis of a serious mental illness, as well as people with substance use disorders, and or people who are pregnant or postpartum. We really want to wrap supports around new moms, babies, and families with very young children and support them during that time in order to set up for stability. And we want to also be able to serve people who are incarcerated and at risk of homelessness. The intersection there, you have the same populations, and then aligning with our other reentry supports and food as medicine supports definitions, we have targeted identified sets of chronic health conditions that we are proposing to serve. So that would be individuals who are in active cancer, receiving chemotherapy or radiation treatment, end-stage renal disease, receiving dialysis, as well as folks with chronic pulmonary disease requiring oxygen, and folks with type 1 and type 2 diabetes, where they may require at least one injectable insulin per day. And in that, we note here, as we said, we want to reduce preventable hospitalizations, and poorly controlled diabetes is certainly one of those areas where we think we can make a tremendous impact by providing access to housing. In this next session, I will try not to read slides directly to you quite as much, but we wanted to go through some of these technical definitions from the standard terms and conditions where the exact language is important as far as understanding what is possible in these opportunities. So we have housing and home environment interventions without room and board. And in that, we are proposing to have case management services for access to housing. That's going to involve activities many of us know, and many of you are delivering these activities already in the community on a daily basis, or your staff is. So that's folks who are providing linkages to other state programs, community resources, benefit program application assistance, helping outreach and do education with individuals. We also have the provision for what we are calling housing navigation and tenancy supports. So that's going to be pre-tenancy navigation services, helping people to find and secure housing, outreaching to those landlords, reaching out to leads that they see, helping with the application process, doing the negotiation to get that lease signed and get move-in set up. And as well, we have tenancy and sustaining services. Once folks have moved in, we want to help them make sure they can keep that housing moving forward. So that would be education about eviction prevention, tenants' rights, helping folks set up the practices that are going to help them be a good neighbor and make sure that they can keep that tenancy. And if any issues come up, understand what their rights and responsibilities are and support them in meeting them to keep their tenancy. And we'll move to the next slide. So the next, we have further ones of interventions without room and board. We are able to provide one-time transition costs and moving costs other than rent to assist with identifying, coordinating, securing, or funding one-time necessary services and modifications to help someone establish a basic household. So that could be items like relocation expenses, security deposit, utilities, activation fees, application fees, moving expenses. There's also the ability to potentially provide utility assistance that is capped at 6 months per demonstration period, but it is nice that there is some flexibility that it could be for back payments as well as payments for those months that they're beginning tenancy. So it gives a little bit of flexibility in that space. Sometimes you do find that when you're moving someone out, maybe they didn't realize they had a couple months due from where they had moved out of in the past. So that can help provide the flexibility to get folks back turned on and to stay current. I do want to give one more comment on this slide. When we see the one-time transition costs, I wanted to note here, Medicaid is a payer of last resort, and it's important to remember this throughout. So if there are existing community resources that can readily pay these, it is still responsible to use those other existing community resources first. But if there's an unmet need that's really critical, it could be. So an example might be in your community, maybe you have some great partners who have, something like a furniture bank, and they can help provide many of the items, but maybe they're not able to provide a bed timely. That can take some time. Maybe they have to work with a purveyor. So it might be able to help provide a bed, but then other items would be provided by the existing relationship with the furniture bank or community resources. And we can move to the next slide. So in this one, this is now we get into the part that is really new for Medicaid. So this is for housing supports or housing and home environment interventions with room and board. Historically, any coverages related to room and board have been off limit and not permissible within the Medicaid programs. First in California and then increasingly to a number of other states, CMS said that they were willing to provide short-term, time-limited rental assistance or payment of rent for up to 6 months. So here we were approved to pay rent-only supports or time-limited subsidy interventions limited to a clinically appropriate amount of time that can include first month's rent as a transitional service and that short-term rental assistance with room alone or with room and board together without clinical services included in the rental assistance payment with that limit of up to 6 months. So that's exciting. It's something new that we haven't had in the past and often sometimes can be challenging to find in the community. Maybe someone needs a bit of time to get set up. I mentioned that we're proposing to serve moms, pregnant people who are expecting a new baby. Maybe they have a gap in their employment. They could be set up in this time period, help them to get connected to childcare, get them connected to employment after a few months with their kiddo, and then be able to be set up for success in the future. So we're really excited about this short-term rental assistance and the ability to provide it for folks who maybe you weren't able to find those resources in the community in the past. And we can move to the next slide. So looking ahead and telling you what is coming. So as I noted, the major thing that we want to focus on right now, we have that proposal for $4.8 million in the state fiscal year budget for the reentry program. It's really important to educate and engage with folks to understand what these resources could bring to your community in terms of improving the reentry experience for folks. So we want to have that get approved and build the foundation for Keystones of Health for the future. All future implementation is contingent upon those budget appropriations from the General Assembly. We will be planning to meet over the course of this summer, June through August, with this, what we're calling a Looking Ahead series. We will be working on developing a monitoring and evaluation plan. As I mentioned, all 1115 waivers have requirements for independent evaluations. There's ongoing reporting throughout the length of the waiver, reporting at the end, midpoint evaluations. So these are really quite rigorous, and we want to ensure that we have and are collecting all the right information to be able to demonstrate the outcomes that we want to show. And the other thing that we will be doing is working on an implementation plan. We have an implementation plan due to CMS this fall, and the series this summer, June through August, where it'll be less of me talking and us talking and more of us discussing together in breakout groups, will be identifying the key factors that are going to set us up for success in that implementation plan. The other thing that we will be doing is we'll have a more targeted engagement series where we'll be reaching out to do some invitations and meetings with continuums of care, who are those regional homelessness response systems, as well as counties, and the folks who administer what is called the homeless management information systems. These are required by folks receiving HUD funds for a number of their dollars in order to show enrollments and outcomes for folks that we serve. So we'll be working together to align on data sharing opportunities. We've had already some more limited but really helpful agreements set up with many continuums of care and many counties, but not all throughout the state. So part of our work here will be working to expand that network. And the arrangements we have so far have been limited to research. We want to look at expanding that scope of data sharing related to the 1115 to make sure we have that data and to be able to show it for our evaluation and monitoring, as well as for operation and planning for the 1115. And we can move to the next slide. So as we noted, we have these deliverables due. Some caveats that I want to emphasize: the deliverables do not obligate us to implementation, but we have to meet these coming deadlines in order to have the option to have these tools available to us. So that key focus will be on the evaluation plan and the implementation plan. The sessions for the remainder of the summer will be virtual sessions to facilitate dialogue with a focus on informing these key performance indicators and the needs for program success, and ensuring some robust engagement and input and making it easy to participate. And we can move to the next slide. Some of the items that we anticipate working on as we get underway: we anticipate that future sessions that will be digging into items like screening and referrals. What could a process be like to do the screening to identify someone who is eligible for these services? We will look at referral mechanisms. Once we've identified someone who has a need, how can we connect them to a provider to receive these housing support services? We'll look at client enrollment and engagement. So what does it look like to successfully work with someone to establish that rapport? How do we initiate services? How are we then looking at measuring and maximizing the impact of those services? We'll plan to spend time on that maximizing impact in service delivery. So how do we ensure that the services getting out to the community are high quality and meeting the aims of Medicaid to improve access to care and help people lead healthier lives? And then long-term impact. We want to show that these interventions have time. Sometimes we see that with folks who maybe have deferred care in the past. For people experiencing homelessness, maybe they have not been able to access routine preventative care or primary care for a period of time. So we sometimes see that folks may have a short-term escalation while they're working on addressing unmet needs, and then stabilize over time as they've been able to connect with the care that they need and get supports, that those costs come down. So we want to measure over time. And then we'll move to the next slide. I do see a question in the chat. We will get to questions in just a little while. When we sent out this invitation, we did ask folks, what are you excited about? And so we thought it was nice to show you a bit about what we received back. So it was helpful to see that some of the themes that came out were, expanding, housing, permanent, people, transitions, opportunities, resources. And it really, I think, shows about some of the ways where we can connect with one another and work together in new ways over time. So thanks for your excitement, and we share it with you. And we'll transition to the next slide where we'll talk a bit about some of the questions that we have received. So with this, some of these are word for word what you sent in, or we had really similar questions, so we just paraphrase them together. So some of the questions received are, how do we target resources to the right members where we can see the greatest impact? What are the eligibility requirements and limitations? Some of that we did, I think, talk through today. So talk through some of the eligibility requirements as far as populations, as far as definitions and limitations. These are time limited interventions, but making partnerships with housing agencies, housing providers, with folks who have permanent rental subsidies where they exist, and being able to connect people to increase their income so rents could be sustainable over time. And then how will this be rolled out and integrated with other available resources? That is a great question, and exactly these sort of items what we want to dig into in the course of the summer together. And then how quickly can we get people the housing that they need? So once we have identified someone, how can we identify the practices to try to get them into housing quickly, and what will help people to do that? And this is an area I think where we can learn and share together. I think some communities have figured out some great strategies for how they do this, and making connections with landlords who are willing to rent with lower barriers, who are willing to overlook criminal records, coming up with some different strategies that have worked, and then targeting resources to the right members where we can see the greatest impact. These are all fantastic questions for us to dig into. And we can move to the next slide. So this is a great one too. What can PA learn about the startup implementation challenges that other states have encountered and strategized? Fantastic. We have engaged through some national opportunities for technical assistance, or different communities coming together, and built relationships with other states. And they've been very much willing to care and share their experience of both what works and things that they would caution others about for the future. So we sometimes have seen, for example, some states thought, I can deliver a wider program to all people experiencing homelessness. And then as they dug in, they maybe said, I need to limit it much further back to only people experiencing chronic homelessness, who are long-term homeless over 1 year with disabilities. And that's certainly a priority population that folks want to serve, but they're often prioritized by other funding sources. So we are really aiming to have a more flexible approach that can support families who maybe aren't going to be identified as chronic in Pennsylvania, which is a good thing, but we want to ensure that pregnant people and families where they have a new baby expected, that we can support those individuals. And we've learned some other lessons from them as well. Another thing we've learned is that these changes take time. We're all really eager to get started over time, but as we noted, we're going in this stepwise implementation. There's a number of changes happening at the federal level. I think one of the, not elephants in the room, but really something we all seen, is we saw the release of the federal, this what they sometimes call the skinny budget, the really high level proposal for the next federal year, as well as the House issuing out their proposal for some pretty substantial changes. So in that, it's really important that we preserve and protect Medicaid. And I will throw in the chat one resource that I want folks to be aware of. Hopefully you've heard about it already, but DHS has put together a really robust data dashboard that educates on the more than 3 million Pennsylvanians who are served by programs we administer, like Medicaid and like the Supplemental Nutrition Assistance Program. You can get localized data broken out by legislative districts, by county, on who is being served by Medicaid in your community. And we really want folks to be able to see and lift that up as folks understand how we can protect and preserve Medicaid in times to come. How can individuals ensure they receive up-to-date information on available housing resources? Great question. This is a really tough one and something that has actually come up a lot in the housing navigation and in discussing the creation of PA's first statewide housing action plan. We're really thinking about some new tools and maybe one-stop shops to help people better understand the resources that are available and keeping that information more centralized for folks for where to go. Because we do recognize that right now can be pretty challenging navigating a lot of different agencies, levels of government to understand. So we're looking at developing something on our side where we can. And how can we ensure that support is available for individuals who may need assistance to connect to resources? Thankfully, many of our definitions that are approved for service delivery exactly speak to that. So we're really excited to dig in. And at that, I will note if we could just go to the next slide. And then I am going to talk through here. So I'll spend some time because I see there's a couple questions in the chat. So how will service providers get qualified to deliver services and the waiver? So what I would note, Ellen, is that that is something where I hope that you will attend some of the next few sessions. We've heard that, you know, a lot of states have been wrestling with this. How do you help people figure out provider enrollment, or what are some different systems and structures? We've seen some states look at operationalizing using a program administrator where they are the ones potentially submitting claims and initially in the beginning on behalf of providers. So I would say it depends. The Commonwealth did release a requests for information on the potential role of a program administrator in this. In that, so we received information that we used as we were thinking about planning, but no decisions in that space have been made, and conversations over the course of the summer and engagement together will help us figure out what some of those models look like going forward. Similar with who will be billing Medicaid, those are items that we will work together to deliver over time. We have seen other states sometimes have proposals where they have trainings available or technical assistance. I mentioned that some of the dollars for reentry are for infrastructure is what we are first proposing. We will also have some resources available for infrastructure and capacity building for these health-related social needs interventions. So we would be looking at working with processes to figure out that readiness and to be able to make it easy as possible. So it's something we'll build together, but I assure you support will be available regardless of the pathway that folks choose to go forward with. And then are there housing subsidies or vouchers attached to any of these supports? Michelle, that is a fantastic question. What I would note there is it has been highly encouraged that in delivering some of these programs to work to establish partnerships with continuums of care. So folks who may be operating rapid rehousing programs, permanent supportive housing, housing choice vouchers through public housing agencies. It is really, really helpful to be able to identify those to figure out that bridge for stability. So that is what we would envision and hope for, and working with different housing providers in your community to set up for success. And we have engaged with some of the public housing agencies around the state as we start thinking about what this could look like down the road. And then I do just want to see lots of fantastic questions in the chat, but I wanted to also give a moment and see if folks wanted to raise their hand. If you had a question you wanted to share out loud, happy to take some of those and we can work to unmute you. So I'll just pause and see if any folks want to ask questions that way. Okay, so I think we I'll keep an eye out, but it looks like we have a lot of questions in the chat. So how can we operationalize the concept of warm handoff for people who may have communication challenges due to emotional regulation, acquired brain injury, and other issues? That's a great flag. And, I'll note there is some research that unfortunately for a lot of folks experiencing homelessness, sometimes they have a statistically higher prevalence of traumatic brain injuries in the population. So I think it's going to be really important for folks to work together and to be informed by the evidence. We would ensure that there are resources for folks who may have English as a second language and seek to work with providers who have this capacity and have this knowledge, and also to develop it where it may not exist already. So again, I think it's going to take partnerships, but you're exactly right that we have to think about folks who have varied experience in communication styles. Also, that may change how we support them in ensuring tenancy moving forward. And then for the capitation, Missy, I'll note for that's an area where it's something that we could discuss in the future down the road. But in the engagement series, I think we'll really be looking at this in the planning for implementation, letting us know what you need for success as far as operationalizing. Can these funds be used for non-traditional housing types? So I would say, I see Isabel's question about non-traditional housing types. We do want to look at for this, we want to support people to have, find, and maintain independent housing in the community. And we are envisioning these being items where you have a lease, where you have the protections of tenancy. Folks can take a look at some of those for recovery housing. Our folks, our partner agencies at the Department of Drug and Alcohol Programs and some others have some great recovery housing operators. So more conversation to come here, but by and large, we do want to use these to support people for long-term, ensuring their own leases. And there was a flag about PA Navigate. For folks who may not know, there is PA Navigate, which is a new platform in Pennsylvania to address social determinants of health, and as well as to be able to meet needs. And that is a partnership with health infrastructure organizations and a lot of healthcare entities around the Commonwealth. The Community Action Association of Pennsylvania is one of the partners in that, and they're working to onboard community-based organizations. It is a great foundation, and we do hope that there will be some engagement and interaction with some of that platform. I know that's come up in the food as medicine discussions. Housing affordability. Bob, that's a great question, and that's one that we all have to grapple with. The other thing I would note there with available housing affordability is this is something where I mentioned that the federal budget, I think it's really important that we lift up the essential need for continuing and growing funding for housing, for programs under the Department of Housing and Urban Development, as well as others. We did not get into the housing crisis on our own. We've underbuilt for over a decade since around the 2008 financial crisis. It's one of the reasons why we're working on the creation of Pennsylvania's statewide housing action plan to lower barriers. So what I would note is this is going to be an all of us effort in order to address this. And hopefully we can also educate our folks, our colleagues at the federal level, as folks are looking at the federal budget, to ensure that those resources are available too. Yeah. I will just take a moment and see if anyone else wants to be brave and come off mute. But otherwise, we can certainly give you some time back in your day. Daniel.
I'll be brave. I just want to clarify that in the beginning of your slide set, you mentioned state prisons. Will individuals incarcerated in county jails also be eligible?
Yeah, so in that proposal, is a great question. So in the proposed implementation for the reentry supports, we propose to start with state correctional institutions. And we know that currently there is a lot of partnership with counties as folks plan for transitions out into the community already. And so in the beginning, we would begin with that implementation with state correctional institutions. And over the course of the 5-year waiver, there are plans to extend the reentry supports to a small number of county jails as well. So it is in the plan, but it'll be in further years down the road. So great question, Daniel. So I will note here, just going back to the slides we have, you see a little bit about what we are planning to discuss. For folks who have joined today, you are absolutely will receive information about registering for future sessions. We will also be keeping information updated on our website. So the registration for future sessions, if you aren't receiving it by email, you will be able to find it on our main 1115 demonstration website, which is Keystones of Health, as well as you can subscribe to receive our email updates if you do not receive them already. Please subscribe to our listserv so that you ensure you receive timely updates in the future. I'll hang around for a couple more minutes, but we want to thank you for joining today and for your interest and excitement. And we look forward to meeting closely with you over the course of the summer. And we understand that there are limited resources, but we hope that we can work together to expand the resources available and expand and grow partnerships in this space, and look forward to doing it in partnership. I thank you and I hope you have a wonderful afternoon. Take care, and we look forward to seeing you in June, July, and August sessions. Thanks.